Hello, everyone. Thank you for joining us for another edition of the World Stroke Conference Fellow Interviews. The purpose of these sessions is to provide stroke fellows and trainees the opportunity to sit down and chat with leaders and experts in the field. My name is Yogendrakumar, and I am a stroke fellow and doctoral candidate at the University of Melbourne in Melbourne, Australia. And today, I have the pleasure of sitting down with Professor Fischer. Professor Fischer is a stroke neurologist and chairman of the Department of Neurology at the University of Hospital Basel in Basel, Switzerland. He is a lead investigator in several trials, including SWITCH, ELAN, and SWIFT Direct. The results of the latter most have been presented at both ESOC and yesterday at the World Stroke Congress. Professor Fischer, thank you for your time.
Thank you very much for inviting me.
And so first, let me start off right from the bat. Congratulations on completing SWIFT Direct. SWIFT Direct was quite a trial, an acute care trial in more than 30 centers across both America and Europe. Can you describe what that process is of developing that large research framework? And did any role of having SWIFT Prime in place help out with that?
Yeah, thank you very much for this very important question. I can tell you that performing such a trial, it's really a marathon. We started already back in 2014 with the idea that eventually we could or we should test whether TPA in patients with large vessel occlusion who are candidates for mechanical thrombectomy, that TPA could be skipped. But at that time, this was completely a no-go at this because nobody was really appreciating this idea. So what we started first, before we even started to perform the trial, we started to perform our own research projects. As you know, at that time, I was at the University Hospital in Bern. And there was a period when endovascular therapy started, especially before the randomized controlled trials were published. We were not aware whether the addition of TPA was improving any benefit or any harm. Especially, we were a little bit scared about the bleeding complication. So in clinical routine, we already had some experience in skipping TPA in these days. So therefore, we started to perform first retrospective analysis of our own cohort, looking at patients treated with direct mechanical thrombectomy who would have been eligible for TPA, and we compared them with the other ones who received bridging thrombolysis. And we could not find any major difference, and that was the reason why we thought, well, this is a monocenter trial, let's compare it with others. So we reached out to German center in Essen, where they also had the same experience. We started to pull together all the evidence, and then we had our hypothesis based on this retrospective analysis, and we went to a company asking them whether they would support such a trial. And the company was very keen. The problem was that FDA was not that, was quite reluctant in supporting such a trial. And that was the reason why we then designed an investigator-initiated clinical trial, but which was supported by industry, which was obviously a lot of help. But this was only the idea and the start of the trial. And then we had a lot of hurdles. I can tell you, I had a lot of sleepless nights because of such a trial, because executing a trial is a marathon.
So then, if I understand it correctly, then, we have the landmark trials that are coming out in 2015, but the concept of SWIFT Direct was in your mind before even those landmark trials were out. Is that fair to say?
Yes, that is correct, because, I grew up in a center in Bonn where, even when I was a fellow, thrombectomy or intraarterial thrombolysis was already established. So we rather performed intraarterial thrombolysis and thrombectomy rather than intravenous thrombolysis. So we came just from a complete other concept. And so therefore, for us, this was clinical routine. And therefore, the idea of the question whether TPA is beneficial in such a condition was quite obvious. And probably it's also a little bit the fate of history. Why has thrombectomy been invented before TPA? I mean, if it would have been the other way around, people would just do the trial looking whether TPA on top of endovascular therapy would be beneficial. So it is an obvious question. And I think I'm very happy that we now have much more evidence than we had 6-7 years ago.
Absolutely. So let's talk about those challenges, though, because I think that's where, this is the type of thing this is the benefit of these one-on-one conversations, really understanding the mechanisms and the complexities that come with trials. Can you talk to me about some of those sleepless nights and what happened in terms of challenges to get this thing off the ground?
So first of all, we did not have a lot of experience in performing randomized controlled trials. I'm the PI of the switch trial, which we eventually can discuss later on. So I've had some experience already in running investigator-initiated clinical trials. The main or the most important thing is, first of all, you need a team. You need a trial team, a local trial team, which helps you to set up the whole system. So I had an excellent trial manager, a trial coordinator, and we had the help of the clinical trial unit at the University of Bern. So everything, database, statistics, and monitoring was done by the clinical trial unit in Bern, but they did not have the network and the experience to run such a trial, because this is what the experts have to bring with. So we had the trial manager, the trial coordinator, they experienced database, statistician, and monitoring. And I was very happy and lucky to have a broad network of colleagues around the globe. And somebody once told me, if you want to do a trial, you need a lot of good friends. So that's the second thing. You need the local team, you need the trial network, and with the trial network, you have then the capacity to perform such a trial. But then you have multiple hurdles. The question, for instance, was skipping TPA in patients with large vessel occlusion who are candidates for thrombectomy. Is this a device trial? Is this a drug trial? And in Switzerland, it was clear, as for instance also for Mr. Clean, no IV, this is neither a drug trial nor a device trial. However, we went to Germany, and our nightmare in Germany was that we went to the first ethical committee, and they said, yes, this is neither a drug trial nor a device trial. We spread out to other ethical committees, and the seventh ethical committee said, wait a minute, you are skipping a drug, and you're testing a device which has been approved in combination with the drug. This is a drug trial and eventually also device trial. So they went back to the first ethical committee, to the lead ethical committee, and said, okay, that could be right. And the first ethical committee was pulling back the positive opinion. So and we then had to hold the trial, and we had to resubmit the whole trial to regulatory bodies. And in Germany, the physicians who are running trials, they have to be skilled in running drug trials and device trials. The problem is neurologists are experienced in drug trials, endovascular colleagues are experienced in device trials. So we had to train physicians. So you see, this was a complete nightmare, and this decision costed at least 1 year. We could have completed Swift Direct at least 1 year quicker if this would not have been the case. So these are one of the hurdles you can face by doing such a trial. And it was not predictable, because we reached out to the ethical committee. They said, listen, the first ethical committee said, well, this is neither a device nor a drug trial. And we based our decision on this first ethical vote. So as you can see, it is a huge challenge.
Yeah, absolutely. And so speaking on the fact that, like, as you mentioned, the ethics committee was one major barrier in terms of device versus drug trial. When it came to how you were going to be able to get ethics from patients and getting the ethics of getting consent, what were sort of the determinations then from the ethics committees? Was there any consideration to be allowed to do deferred consent in these trials? Was it always pen to paper? And how did you manage that, given this is an acute trial and you're trying to treat the patient as quickly as you can, while at the same time going through the consent forms if it is indeed pen to paper?
Well, you mentioned an extremely important point. I think one of the major challenges of these no IV trials is that, in contrast to Swift Prime and all the other pivotal trials, we had to speed up extremely, because we had to get consent before start randomizing the patient, and we did not want to delay TPA, because this would have been unethical. So in Swift Prime, it was much easier. The patient was coming in, you started standard of care, and then you could randomize either endovascular therapy or not. So this was a major challenge in these trials. So and regarding the consent procedure, this is also something where you realize even Europe should be a uniform area. There were a lot of differences between the countries and even within the countries between certain areas. So we were focusing on countries where you can get emergency consent by an independent physician, and then you have to seek referred consent. And then the procedure, what you have to do if you do not get referred consent, is different from one country to the other. So as you can see, this was a major challenge, but I think at the end we managed to get enough patients randomized. But for instance, this was also a reason why we could not go to the United States, because in the United States, referred consent in such a condition is not possible, and IVTPA is in trials is only licensed within the first 3 hours. So this is also a major challenge then, whereas in all the other countries you can randomize patients up to 4.5 hours.
And so when you mention the notion of then deferred consent and the differences between regions, has there been any change now in some of your upcoming trials where the precedents for deferred consent being safely applied now allow you to be able to use deferred consent in trials that are ongoing? Or has it sort of continued to be on a trial by trial basis and it's been hard to sort of move the needle?
Yeah, this is an important question. There are countries where even consent by next of kin are extremely difficult or even impossible. So for instance, in countries like Ireland or also Portugal, consent by proxies is a major issue. And that is a challenge for at least for stroke trials. I mean, in stroke, people, they have a problem. The brain is affected. They are aphasic, or they are simply not able in a state where they can consent. And often I'm really a little bit puzzled by the lack of understanding of the ethical bodies and even also of the countries or the regulatories, that you cannot randomize a patient in such an emergency situation, because how are you getting answers to these kind of unanswered questions if you do not trials? So this is a major hurdle, and we are trying now with another trial, with the ELAN trial in Ireland, to get also consent by proxies.
Fair enough. Now, switching gears a little bit, because something that you alluded to in terms of what's really important for success in a trial, and you mentioned having a good clinical trial team locally at the site. Can you talk to me a bit about what were some of the attributes or qualities of a good team member when it came to running a clinical trial unit? And what were sort of the qualities that you looked for in people that you hired or people that you brought in as collaborators at the local level, in terms of research associates, research assistants, or even PhD students?
Well, thank you. This is an extremely tricky question. I think having these teams is very challenging, especially over years. I really try to focus on juniors, because these are the people who are really committed and who are keen to get such a study done. So I think that is something which is extremely important, to get people. On the other hand, the downside is they do not have a lot of trial experience. So, but I think that the methods and the things you can learn quite straight away. It's not rocket science. On the other hand, I think it is extremely important that these people are working very precisely, because quality matters. I think that is the most important thing in clinical trials. You have to make sure no patient lost to follow up, visits within the frames, good quality of the data. Otherwise, it's extremely difficult and also to publish. And we have invested so much time and energy and also money. And if the quality at the end of the day is not good, then it's a waste of resources. So I think finding young people who are committed and having their own baby. Even in trials when we had several people working on one trial, I really tried to give them one area where they were responsible for, where they could see, for instance, if there was a progress, that they were responsible for this progress. So, but motivating the team is quite a challenge. And to be honest, I had also some kind of fluctuations in the team, especially because these are young people. Then they get trained in clinical trials, and then the drug companies are coming saying, hey, I have a job offer. and they are extremely, they have an excellent knowledge, and I cannot pay what drug companies are paying, obviously. So, but I think all of them made their career and had a good let's say a good way to move on. So I'm also very proud to be the mentor of these people and helping them to get the right place in their life.
Yeah, fair enough. And just talking a little bit about the team, what the team consisted of, and just looking at the differences, for example, coming from a Canadian or Australian perspective versus in Europe. What were the members of your team? Were they a lot of sort of doctors who had finished their medical training, now doing a PhD? Were they individuals perhaps that had done a bachelor's or a master's in a certain area of science and now is doing a research associate degree? Can you sort of talk about what the team consisted of, in numbers wise and role wise?
So I think there are several things you have to know. In Switzerland, we do not have the same PhD culture as, for instance, in UK or the Netherlands. So I think in the Netherlands, and they have the Mr. Clean people, they have a whole team of PhD students. I think for the Mr. Clean OIV, they had 3 to 4 PhD students working on the same project. So this kind of culture does not exist, and we do not also have the resources. By the way, we can talk about it later on. I was establishing a PhD program in clinical science at the University of Bern, just simply to get also in future more PhD students on board of these projects. So the people working on Swift Direct, one was clearly a PhD student. Is Johannes Käsmacher, who has done a lot of also publications around the topic. And then we had mostly people with a master's degree in biomedical sciences, biology or biomedical sciences or this type of degrees. And we always had somebody senior who already had done trials, who had clinical trials experience, who also was working with a company or with Swissmedic or with another institution with the experience in randomized clinical trials.
Gotcha, fair enough. And so when we talk about teams, we're talking about leadership then. What were sort of your steps in terms of your sort of evolution to become the lead of a clinical trial like Swift Direct? And this is a very expansive question, so by all means, you can take us through a little bit of the history of where you did some of your training in Oxford. From what I understand, looking at your bio, you came back to Switzerland. You were at Bern. You became the deputy director, then the co-director. What were sort of the process that sort of led to those steps then to say, okay, I can start leading this trial here?
So I think first of all, with Swift Direct, I was not alone. We have a co-chair. It's Professor Jan Gralla, and he's a good friend of mine. And we always had this kind of team approach, also from a leadership perspective. As you probably know, we also established together the Stroke Winter School in Bern, which is a teaching course for young people. We had done a lot of clinical projects together, how optimizing patient flow in the emergency room, and so therefore we already worked together on a clinical and educational basis. And then you start to learn on your errors. You make mistakes, even with hiring people. You make mistakes with prioritizing. I think the most important thing is to become a leader is to be authentic and to be yourself, and to try to find a solution together with the team. It is if you do not have the team, if you do not listen to what the other says, you will not succeed. And so it was a continuous process, learning by doing, and we also could talk about all the errors we made in the framework of all these trials. So yeah.
Well, that leads into my next question beautifully. Can you talk to us about some of the lessons you learned from some of the earlier mistakes that were made when you were sort of first starting, maybe not even Swift Direct, but just like earlier trials, observational studies, really prospective data collection and the process that comes into that? Can you talk about some of the things that you learned really quickly on and sort of took those lessons to those subsequent trials?
Well, I think one of the things at least for clinical trials, what I learned is that probably at the beginning I was too cautious. And it's also obvious because if, as a junior you do not have a huge budget, and so you're scared that all of a sudden you have suspended all your money and you cannot do it. But looking back, I think I was a little bit too cautious. I think, and it's not my personality, but the concept of think big is probably not too bad for if you want to do these trials. You need a team, but then you have to spread out quickly and you have to maximize your sites, because if you start only with 5 to 10 sites and you ask people how many patients are you going to randomize, and they say, well, we're going to randomize 20 a year. So then please divide what they say by 10, and then you end up with a realistic number. So a site saying, well, we're randomizing 20 patients per year, they will randomize 2. A site saying, we will randomize 100, they will randomize 10. So this is the reality. So these are the things you have really to learn during these kind of trials. So think big, be cautious, but don't be afraid.
Gotcha. And when it comes to finances, that seems to be one of the biggest barriers when it comes to being able to run those large trials. Can you talk about what was the funding structure set up for SwiftDirect? Like, how did you set that up, and what was the process to get the funds in place to be able to support other sites for them to recruit?
Yeah, it's an important question, and in the SwiftDirect, we were in the fortunate situation that the trial was supported by industry. So as I already mentioned before, we contacted the company, and initially it was planned that this will be a company-driven trial, and then we changed to an investigator-initiated clinical trial supported by industry, which was, from a trialist perspective, also a huge chance, that then you have also the opportunity to learn. Because if a company is doing a trial, they have a clinical research organization, they have professionals doing these kinds of things. So it's another experience when you do it by your own. Regarding the other trial, they are so-called poor man studies. They are supported by the Swiss National Science Foundation. So ELAN and Switch, and therefore, so the sum which I can pay to the sites is minimal. So it's so therefore it was extremely important to design the trials in a pragmatic way. And I think that's also an important lesson. The trial should follow the clinical routine as much as possible. And if you want to test biomarkers and follow-up images and so on, this makes a trial completely unfeasible and very difficult. So for instance, the ELAN trial, when we're looking at anticoagulation in patients with atrial fibrillation and ischemic stroke, where we compare simply early versus late anticoagulation, it is so simple that you can do it everywhere. So it became an international trial. We have sites in Japan, we have now sites in India, we have sites in Europe. So if a trial follows the logic of the clinical routine, then the additional expenses are rather low. So therefore, people also recruit patients in such a framework, even though I only can pay them a symbolic contribution. So, but for SwiftDirect, obviously this was different, and it was also more tricky because it was an acute phase trial in the emergency setting and so on.
Right, fair enough. And also it was occurring during a time, or being set up during a time when even the landmark trials were still in development. So fair enough, I can certainly see that there. And so it sounds like pragmatism in your trial development, in your timelines that you create, if you can embed it within routine clinical practice as best you can, those are ones that are easier to execute, get people on board, because it doesn't require them to go above and beyond what they would normally do. And it makes it, again, more practical to do.
Absolutely.
Gotcha. Fair enough. So let's talk about, SwiftDirect. The results are out. You presented at ESOC. You presented some more results yesterday at WSC. I'm willing to bet that I'm sure that currently you are in the process of submitting at some journal of sort, and it will be coming out soon. Can you talk to us a little bit about the process of submitting major trial results to a leading journal such as the Lancet or New England, and how that differs from sort of routine submissions that you would do for another sort of smaller study? Are there a lot more sort of just like off-the-record conversations that are happening with the editors, or is it still very much a rigorous process in the same standardized way?
I mean, I think the submissions are more or less standard. I can't tell you too much in detail because we are just about to finalize the manuscript. But obviously, I mean, it is the same everywhere. You submit it. I think the huge difference is that it is very carefully looked at from the journal, and you have review by the statisticians and so on. So I think it is extremely important that the data quality is excellent, and that you have experienced statistician and people who already have that you have people on board who have already done this. As a junior or a first runner, you cannot do that.
And so this actually leads into another question that I've had. So when certainly as in my experience, I've sometimes had some centers come up to me saying, hey, look, you're interested in research. We're hoping to start our research program at institution X, Y, or Z. And you'll be starting from scratch, but you could set it up your own way. Are you interested? And one of the things that's always made me personally a little bit nervous about that approach is that sometimes you're not sure what you're walking into in terms of support structure. What would you say to young investigators who are sort of offered that opportunity? Is that something that you'd be in favor of, or would you sort of have some reservations about that approach? What are your sort of thoughts on that?
Well, I think first of all, we should be inclusive, and we should try to encourage people to move the things forward, but we should not naive. So I think it very much depends on the infrastructure, on the experience. If somebody is just a standalone person somewhere without a trial team, or with seniors who have already experience in clinical trials, then it's extremely, or in clinical research, it's extremely difficult. You always have people who are excellent and brilliant and are able to build up these kind of things by their own. But even though, for instance, in my institution in Bern, where I was clinical, we never had done a clinical trial in stroke before. But I was in an environment where research was cultivated over decades, and we also had the clinical infrastructure, so that we participated in other trials, so that we at least had some idea, even though we haven't done it by ourselves. And then you need professionals. So I think that the environment is extremely important. So for instance, if somebody's contacted me from a country where they haven't ever done a trial, they even don't have a study nurse, or then it becomes really, really difficult. Then I rather decline.
And I think that makes sense. And so if I'm hearing you correctly, you don't necessarily have to have expertise in stroke per se when it comes to clinical research, but having the culture of research within an institution and the enthusiasm to do that work, that can be a good starting point. And then
Absolutely.
You can come in as a new investigator to bring in that stroke knowledge, work with experts already in the area who may not be stroke experts, but sort of build up that component from there.
Excellent. Yeah, that's exactly the point. Yeah.
Excellent. So while I have you in the next couple of minutes here, I know we got to wrap up soon. Let's talk about the next steps after Swift Direct, which is, you have the IRIS collaboration that is, like, I'm sure the work is currently ongoing, though I think there's a presentation later today, if memory serves me correctly. For those not familiar, the IRIS collaboration is going to be an individual patient data level meta-analysis of all the major trials put together. Now, you have trials that have been based out of Asia, you have trials that are based out of Europe, you have a trial now in Australia that you're going to be integrating all this data together in. How are you managing the complexities of data sharing between different clinical trial teams? What is that negotiation process like?
So first of all, we haven't done it yet, so we will have a lot of new hurdles. And I think the most important thing is, we had this kind of idea of collaboration already before, and also especially the colleagues from Mr. Clean, they started to reach out already. Last year we met at several conferences. We said, listen, as soon as we have the first results, we will start pooling data. I think one of the advantages is that Direct MT and Mr. Clean No IV, they are brothers or sister trials, so at least they have similar protocols, so they know each other. Some of the people working in this consortium, they have experience with the Hermes collaboration. So having already done this, they also have their lessons learned. And so we will meet soon. I will also meet some people at TTST now this weekend in Amsterdam. just exactly to discuss how we now are going to proceed, because we have the problem with data protection and transfer of data and all these kind of things, hurdles which we have to address. And yes, that's our next challenge.
Fair enough. Well, with that in mind, looking to the future, I want to thank you for your time today, Professor Fischer. I really appreciate it. While we have a quick moment here, let's do a quick shout out to the Stroke Winter School. I think applications are currently undergoing for the
Yes.
program that will begin in February 2022. Is that correct?
That's correct. And I can add a small other there is also a so-called Stroke Master program, which will start in spring next year. So people who would like to do a master in stroke medicine are kindly invited to join us here in Switzerland. A lot of the modules are online. There are 3 weeks which are on site. So also due to climate change and pandemics, we try to address these questions. So if you're interested in performing a master in stroke medicine, please join us.
Fantastic opportunity. And with that, thank you very much for your time, Professor Fischer. We really appreciate it.
Thank you. Have a good day.
Take care, and thank you for joining us.